Okay, welcome back to our next session here at the Interoperability Virtual Day. It's now time for a discussion on interoperability and the Cures Act. Are you ready? A big thank you to our partners at Infor for their support of not only this session, but of course the overall program. With that said, I would love to once again re-welcome onto our virtual stage our editor-in-chief here at Healthcare Innovation, Mark Haglund, to kick off this discussion. Mark, are you with us?
I am with us. Thank you so much, Matt. Thank you to everyone in our audience for returning. We're thrilled to have you here again, and we're going to be talking about a lot now in the next half hour plus. So what I'm going to do first, very briefly, is have each panelist introduce himself, briefly his title and role in organization to the audience, and then we'll kick off our discussion. We have Jörg Schwartz, Bill Howard, Rob Brull, and James McFerrin. Why don't we go in that order quickly, and then we'll plunge in. Jörg?
Hello, good morning, good afternoon. As Mark said, my name is Jörg Schwartz, and I'm the Strategy and Solution Director at Infor Interoperability, a Cloverleaf product. And we will talk to you today about what, as a healthcare system, you can do to not only comply with the Cures Act and prepare for TEFCA, et cetera, but also how you can actually take advantage of it and get benefit out of it. And I'll hand it over to Bill.
Thanks, Jörg. My name is Bill Howard. I'm a principal at Audacious Inquiry. We do solution strategy consulting, but also operate health exchanges in about 15 states with a real focus on alerts and notifications and things like that. And I'm also the chair of the board of the eHealth exchange. And that's a voluntary role, I'll point out, but very involved with kind of more the strategy and sustainability of that entity, more from a business and financial perspective. And, really wanted to share today some of the kind of what's happening in the market. So next, Rob.
Rob, please go ahead.
Hi, I'm Rob Brull, and I'm the Senior Product Director at Infor for our FHIR-based products. So I'll be talking a little bit about today about some of the products and workflows we address related to the Cures Act.
Thank you so much, Rob. And James.
Hello, everybody. My name is James McFerrin. I'm a longtime resource here with Infor, Principal Solutions Consulting. I have worked with many of our customers over the years providing healthcare interoperability. And today I'm going to talk about some of the solutions that are actually being deployed in the real world.
Wonderful. Thank you so much, all of you. Let's start, Bill. A lot of stuff is happening. We want to talk about how the Cures Act implicates FHIR support, but I also wanted to, since we started the day talking about TEFCA, let me ask you what your impressions were after ONC a week ago released the details of TEFCA. Start with that.
Okay, sounds good. Well, I mean, TEFCA and the Cures Act calling out APIs and FHIR, I mean, it's been a long time coming, right? I mean, I actually looked it up. The Jason report came out almost 10 years ago, which really focused on how, health data is just not transportable, interoperable, and it was highly critical and really pushed the industry towards an API first model. And with that, at the same time, kind of FHIR was happening, and now, we're on to FHIR R4, which is really being widely adopted into different electronic health records. And so, with an eye towards TEFCA last week, I think some were disappointed that, why wasn't it stronger on, including FHIR and requiring FHIR right out of the chute? And I think it actually makes a lot of sense the way they positioned it. I mean, they had to go with something that was tried and true in the market with high volumes and has been proven. And, TEFCA really had to go with something, a sure thing. And I think they kind of did a nice balancing job between taking, the SOAP CDA model that is, in the billions of transactions a month right now, but with an eye towards moving quickly to a FHIR-based model. So I think they balanced it actually really nicely, and I think I think it's clear the direction everyone wants to go. But there's the pragmatic part where you got to start with something that's proven, and I think there'll be enough change that will allow TEFCA to get a stable footing on something that's tried and true, and then the other regulations can kind of pile on and say, hey, you have to be part of TEFCA, you have to do this, but you can't do it until TEFCA's out. And so I think it was a really big milestone that was many, many years in the works, and I really take my hat off to Mickey and the ONC team and Marianne and the Sequoia team. I think they really they got it done. So congrats to them.
Yeah, we had last year Cleverleaf Solution Summit, and Mickey Tripathi talked at our summit, and we had a couple of questions, and it was very clear that Mickey is committed to the goals of making data more interoperable, giving full access to the patients. And what we've seen in the Cures Act, like patient data access from payers, patient data access from providers, provider to provider, payer to payer, all goes in that direction. And I think the secondary question is, what is the best technology to make that happen? So in that regard, the technology is not leading, but the goal is leading, right?
Yeah, yeah, absolutely. I will say, I think, I was in on that initial briefing that happened. It was about a half-hour briefing with Mickey Tripathi and Marianne Yeager, and I think they went out of their way to try to be as transparent as possible. It's hard because it's complicated stuff, right? But that day I think they did a good job of explaining things. Bill, were there any surprises from your standpoint?
Well, I think yeah, I mean, I think a little bit surprised. I mean, in the presentation they did, they talked about how the current national networks are doing great work, but sometimes you need the federal push, a regulation or a federal push to really get some of the things that aren't happening to happen. And if you think about it, like today, the national networks are very effective at exchanging data, document-based data for purposes of treatment. I mean, it's just, like I said earlier, I mean, there's literally billions of these transactions a month. I mean, it's massive exchange, but it's all kind of provider to provider exchange for treatment. And where obviously this needs to go is to expand those purposes of use to payment and public health and some of those other purposes that are currently just not really part of the whole ecosystem. And so I think from a was I surprised perspective, if I'm being hard on the whole system, I would say, well, heck, why didn't you come out of the chute with all of those purposes included? But I think, again, going back to the pragmatism, I think that, Mickey and the ONC team and Marianne and the Sequoia team, did a really good job of listening to the stakeholders and getting feedback and coming out with something that's actually implementable, that's not going to blow the whole thing up, right? I mean, they scaled back the initial purposes to really treatment and those that are, consumer directed or consumer inquiries. And I think that's a really good first step. And then they can get that foundation laid and then build on it. So I think to me, that was a little bit of a surprise, but I think I was, brought to reality by the fact that they really, I think, picked the right balance there.
Yeah,
So
I was just going to say, one of our panelists did make the comment that she kind of was hoping that more would come out initially, but understood that this is going to be iterative inevitably. Anyway, I apologize. Yeah, please go ahead.
Yeah, I just wanted to ask Bill, so obviously one of the reasons why they probably haven't been more forceful on FHIR is readiness. So can you give us some assessment of how ready are the national networks versus how ready are the providers to actually transact on an API basis in FHIR?
Yeah, Yeah, it's interesting because, like I said, I mean, the Jason report came out 10 years ago. FHIR has been around through R0 to R1, R2, R3, R4. Now, especially in this year, as certification of EHRs will include FHIR R4, I think this will be a really interesting year. Being an optimist, with an optimistic hat on, I think there'll be a lot that's going to happen in 2022, especially with the signals that are coming from TEFCA and other regulations. Putting the pessimist or negative hat on, many of the national networks, Commonwealth had FHIR-based APIs since the very beginning. eHealth Exchange has done a really a proactive job trying to get Exchange to happen through FHIR. They built their directory so that it's FHIR R4 aligned, and have actually prototyped some use cases, even high value use cases like exchanging prescription drug monitoring program data using FHIR, or there's some work going on right now with enabling the FDA to make inquiries to do case assessment and follow up using FHIR. And what's been disappointing, I would say, is that the level of adoption in the provider market, and obviously some distractions with this little pandemic probably, but in terms of adoption in readiness, it's really not there yet. And being optimistic, maybe these certified EHR technologies and the regulations will push things, but being realistic, and knowing that the Jason report came out almost a decade ago and these things take forever, it seems like it will be a longer tail to implementation, given what's there today.
Yeah, absolutely. I had conversations with Gartner analysts, and they also say that for probably at least the next 5 years, we will see HL7 V2 and FHIR in parallel. But I would like to bring in Rob Brule now. Rob is a senior product manager for the Cloverleaf interoperability product. And Rob, obviously, it's not easy for providers to go from HL7 V2 to FHIR. So can you talk to us a little bit about what we're doing to make it easier to make that jump and get the infrastructure ready for transacting in FHIR?
Yeah, absolutely. So, for many years now at Infor, we've been developing products that are FHIR-based to help move the industry forward. One of those that I'm sharing right now, York, can you see my screen?
Yes, absolutely.
Okay, good. Is a product called Infor FHIR Bridge. And so this kind of bridges the gap between the old and the new and allows old data to be exposed in a modern-based way. And so, when you think of HL7 V2 being one of the dominant ways that legacy data is being shared, we have pre-built configurations that take that HL7 V2 data and converts it to FHIR. So that work's done for you already. So we can take legacy applications and expose that data in a modern way using FHIR, RESTful web services, JSON and XML, and accelerate the speed to innovation that our provider customers and payer customers can use in taking the work that we've done in those translations and getting their legacy infrastructure in the FHIR ecosystem. Now, in addition,
Rob, yeah, I heard about projects that take like over a year to build all the mappings from HL7 to FHIR. How much effort is it to do that with FHIR Bridge?
Right. So with FHIR Bridge, the translates are pre-configured, right? So you're going to have to do some massaging probably with the V2 messages because that's just the way V2 works. They're all a little different. But you can do that massaging, using your legacy engine or using the Cloverleaf engine. And then, once you massage the V2 data, it's just automatically converted to FHIR. And then in reverse, if you need to get that back into your legacy infrastructure, we can take FHIR bundles and put those back into a V2 format. So,
so let me be
very quick.
Let me be very clear. Does that require that somebody has Cloverleaf or in HL7 V2 to utilize this bridging service, or could you use any HL7 V2 infrastructure?
Right. You can utilize your existing HL7 V2 infrastructure, so there's no need to rip that out. And in fact, you can use your legacy V2 engine to massage your V2 messages to get them into a HL7 V2.8 format, which is what FireBridge accepts. But once you're in the HL7 V2.8 format, then the conversion to happens within FireBridge automatically to the FHIR resources. Yep. So that's FireBridge, and FireBridge is, you know, kind of when we started doing this 3 years ago, you know, V2 to FHIR was the big push. But as you'll see in the next couple of slides, we're moving forward to address a lot of other industry needs with FireBridge as well. And one of those is related to burden reduction. So when you look at the Cures Act, there's a proposed rule around burden reduction, and there's some workflows that are defined through implementation guides by the Da Vinci Group at HL7, which we are a member of. And there's 3 workflows that kind of fall under the burden reduction umbrella. So one is coverage requirements discovery. You know, does the patient have coverage for this procedure? DTR, documentation templates and payer rules, which allows for extra information, questionnaires to be filled out for additional information that might be needed to make that decision. And then prior authorization support, which is the kind of the official request for a prior authorization before the procedure takes place. So there's many technologies involved with these workflows. On the coverage requirements discovery, there's a technology called CDS hooks that's utilized, and the prefetching of FHIR resources with documentation templates and payer rules. That incorporates a Smart on FHIR app, which exposes a questionnaire to the clinician using the questionnaire resource. And then for prior authorization support, that involves integrating the traditional X12 technology into FHIR using FHIR to X12 and X12 to FHIR translations. So those are all things that we're working right now to build into the FireBridge product. And so it's evolving into much more than just V2 to FHIR, but is addressing some of these Cures Act workflows.
Rob, Bill talked earlier about high value use cases. Why is burden reduction a high value use case also?
Yeah, I mean, I've seen some reports that say that, you know, of the costs that go into a full, you know, clinical workflow, anywhere from 10 to 15% of those costs are just based on burden reduction, which is the what we discussed there, you know, determining whether the coverage exists and then going through all the prior authorization documentation, cutting and pasting, all the backroom activity. So it is a lot of
time. It's a lot of time for nurses and care providers that they have to pull that information together, and that workflow automates that and cuts the time from hours and days into a very short period because they can do it right then and there. So high value use case. Another one, we just saw a new law come out in Massachusetts that requires patient cost transparency. So you have a use case here that addresses that law. And, you know, my prediction is that there will be probably more states that will enact similar laws.
Right. So for Massachusetts, I think it's within 2 days. They need the provider needs to provide a good faith estimate at the patient request. And traditionally, this is done through X12 messages. But the Da Vinci work group at HL7 has an implementation guide that focuses on this. And the core component of that is FHIR to X12 translations, and then of course X12 back to FHIR, to make this workflow FHIR based for the providers. And so this is another, you know, kind of key area where FireBridge can be placed into this workflow of doing those FHIR to X12 translations. And so just another area based on you know, some of the things that are coming out of the Da Vinci work group at HL7. That FireBridge can help push the industry forward and help with you know, the speed of these workflows being transitioned to FHIR.
Yeah, Rob, and we actively work on the Da Vinci work group, so we're not just sitting there waiting for them to come up with these things. So we actively influence that and implement this for our customers to get the value of it. So I would like to bring in James McFerrin now. James is a principal solution consultant, and he's been working with customers for I don't know if I can say this, James, how long, but it's over 20 years. Let's leave it at that. Over 20 years. So tell us how customers have been using FHIR so far and how we have been helping customers to utilize that technology.
Yeah. Thank you, York. So I have been working with many of our customers. We've done over 24 different FHIR use cases with those, and we do have those all published. You can contact us to get a list of those, but many of them are around the Cures Act, right? I'll talk a little bit more detail about that in a second. And oftentimes it's just about enabling that clinical workflow. I'd love to work with organizations developing their qualified network and becoming that on-ramp into the national network. When you look at the provider side of our house, we have over 10 organizations who have deployed our FHIR product that Rob was just discussing. Most of the time, the predominance of them are simply HL7 to FHIR and FHIR to HL7. And I'll speak to some of those explicitly. But the growing market, it seems like, for us at least, is the payer side of the house, where all of a sudden now with Cures, they need to understand clinical data, which they could previously somewhat ignore. And so we have our tools to help them provide that and meet some directory services, providing their members a list of the physicians. When you talk about, let me close this down here. When you talk about the HL7 to FHIR components, like I said, most of them are just straight FHIR to HL7, ADT, observations. Most of those are typically what's being used. When you start getting involved in the workflows, I've seen there is an organization using FHIR as part of their registration process, so they can capture patient demographics and interact with the patients as needed, as well as we've seen working with some device organizations where when certain orders hit that device, they need to go get the latest patient information, height, weight, body mass, etc., so that they can properly process that order. Finally, I've seen FHIR being used in the traditional sense, where organizations who are more cloud-based, they are exposing those API, those FHIR-based services, but of course their internal systems are still HL7, so they use the FHIR bridge to expose that FHIR and then take those orders inbound as special and send those orders outbound, but the outside world sees everything as FHIR. And if I were to focus on what we talked about earlier, you do not have to have Cloverleaf to run FHIR. It complements either Cloverleaf or your existing engine. You do not have to be trained on Cloverleaf, no certification. All the interaction with FHIR is from your browser or your mobile device. If I talk about other use cases, non-HL7 use cases, we do have our large organization out on the West Coast who's using FHIR to track and notify patients for their scheduling around COVID vaccinations, particularly those impromptu locations that come and go. They had the option of using their EMR, but it was just going to take months to get done. But with FHIR, they were able to do it in weeks and become and had a huge success providing this with their COVID, and had a tremendous effect on their vaccination rates. You'll see that I'll talk about in a little bit more detail about some payers that are using our FHIR product to consume that legacy data across multiple states, so they can provide their members their provider directory services. And we actually use FHIR now in FHIR to consume those C-CDAs, just like talked about in the TEFCA Act, where although those are traditionally IHE, XDS, XCA style transactions, we're wrapping those up in FHIR so that FHIR becomes the vehicle for transmitting those. We're actually doing this in some countries in South America. This could be the first step toward meeting, your qualified networks. Now, let me just mention a little bit, if you expand this and you add the FHIR server, we can really do some amazing things. Everyone I talk to is always asking me, how can I do the scheduling and appointments and change, digitally through my front door? And
yeah, digital front door is a big topic, James. We did a survey at the Chime Fall Forum, and we asked questions, and the majority of respondents, over 75%, said that digital front door was one of their top initiatives right now. And when we asked, what is your number one application that you want to get done through the digital front door, it was scheduling.
Right. Yeah, because that allows them to convert those, my favorite phrase is you converting consumers to patients, right? And that just means so much for those organizations. So, you have your HO7, you have your traditional SIU, but with FHIR, now you can interact with all these and create what I call the single pane of glass, scheduling across multiple platforms. And so we have proof of concepts we've done around that. And as well as, and I love this second one, we taking all this HL7 data, pumping it through our FHIR bridge, very simple, just connected to an HL7 port, sending that over to our FHIR server. Now, once that data is in the FHIR format, not only can we do just standard FHIR queries, that's fun, but what's really interesting are these subscription services. Now, I have all these stakeholders who are interested in these patients, and they want to know, when is that patient going to have a new encounter? When does that patient show up in the ER? What did my patient just get new medications? I want to know about it. And all these kind of events are easily done using our FHIR server services coupled with our FHIR bridge. Lastly, I wanted to talk about Consolidator. It is a different product. It's similar to FHIR Server. Sometimes I'll say the FHIR Server is a set of FHIR transactions, where the Consolidator is almost like a smart FHIR Server. It does all these cleaning of the data when the data comes in, all this understanding the provenance where this data came from, and exactly parsing that data up into the patient-centric records. And really, we had a customer, some payers, who wanted some real-time clinical data. They needed to make sure they communicated back to their sources when the data was bad. They needed to roll this out across multiple states, 700 different sources, and they wanted a FHIR-based solution. So they used FHIR-Bridge, of course, for that provider directory services, so they can expose that to their members. But they used Consolidator to collect all this different data sources from HL7 to C-CDA to FHIR, and they curated that data, created quality data, normalized data, deduplified data, and where they could then monitor that data, look at the metrics coming in from each source, alert each source from data quality issues, and now they can expose. They're beginning to expose this data now as FHIR to their patients, to their members, and they are looking at various multiple support uses of the data, such as analytics. Consolidator is just one of our Cloverleaf FHIR set of services from FHIR Bridge and FHIR Server and our API orchestration. From a Cures Act, it really provides that USCDI set of core data sources where it's consolidating all that data, cleaning that data, and providing back that UCSI data set.
Yeah, thank you for that summary, James. And the title of the session was Cures Act, Are You Ready? So what we were trying to show here is that you can be ready if you use the right tools, but oftentimes organizations are not ready because they don't have the right infrastructure in place. The last one that you showed, Consolidator, for example, is very useful if you want to meet the requirement of the Cures Act to give patients access to their consolidated clinical records from multiple sources. So very useful tool for payers. All right, and with that, I hand it back to you, Mark.
Well, you all have shared so much important data and information and insights. I'll just ask all members of the panel, what are your final thoughts on really how your advice on what providers should do right now? And I'll begin with you, Jörg, and then everyone else can jump in. What providers should do right now so that they really can be ready for all these changes that are coming?
I think providers should really look into workflows that help them to meet their requirements. I know right now retention of nurses is a top priority, but beyond that, everything that helps cost reduction and burden reduction should be a top priority because a lot of healthcare systems are strained by COVID and the financial impact of that. So don't worry about what is legally required. Worry about what helps your organization with cost containment, et cetera, et cetera. And I think if you can do both, become compliant and improve your bottom line, that's a winner. So that's what I would focus on.
I
Bill?
agree. Yeah, Bill, what are your final thoughts?
Final thoughts are that, you know, the data flow is going to become ubiquitous here, you know, if not this year, in the next years. I mean, it's clear everyone's pushing that direction, and to be thinking about the triggers, like when to trigger to get that information, and then once you get all this information, kind of like what James said, how to kind of boil it down to something that's meaningful. Those are the other two pieces of the puzzle that you'll need to keep an eye on. So thanks so much for including me today.
Absolutely. Thank you all so much. This has been such a great session. I've learned a great deal, and you've all provided great insights. So thank you very much.
Yeah, Mark, somebody asked if the slides will be available. We'll make the slides available afterwards.
Yes, absolutely. Absolutely. So thank you all very much. This concludes this session. And thank you in our audience, to you in our audience for spending your time with us today.
Yes, thank you, Mark. And I'll echo that. Thank you, panelists.
Yes.
Great way to conclude the Interoperability Virtual Day. Before we finish here, I want to once again thank our partners at LexisNexis Risk Solutions, of course, Infor, and of course, Spoke, for their support of today's program. Looking ahead, our next program as a part of this digital health virtual series this year will be on February the 23rd, and that will be the virtual program, Trailblazing Technologies for 2022 and Beyond Virtual Day. That program will feature an opening panel discussion on the near-term horizon technology advancement and the healthcare system, and that will feature Advent Health, Penn Medicine, and UC San Diego Health. And then we will have, as of this time, 9 solution providers sharing their innovations through some fantastic fireside chats and presentations. We hope to get to see you all then. With that said, on behalf of the entire team here at Healthcare Innovation, a big thank you to you all for joining, a big thank you to our speaker faculty, and a big thank you to our partners. We look forward to collaborating again soon, and take care, everybody.
Thank you all.